My name is Angela Sinopoli, and I'm one of the co-chairs of PTAC, along with Lauren Harden, who's sitting next to me here. Since 2020, PTAC has been exploring themes that have emerged from publicly submitted proposals over the years. After each theme-based meeting series, the committee releases a public report to the Secretary of Health and Human Services with its findings and recommendations. We recently posted the June 2023 report to the Secretary on improving management of care transitions and population-based total cost of care models to the PTAC website. Soon we'll be sharing our September 2023 report to the Secretary on encouraging rural participation in population-based total cost of care models. As we've learned throughout the previous PTAC theme-based discussions and several submitted proposals, providers face challenges with implementing performance measures, particularly for total cost of care models. We know that this topic is also of interest to the Innovation Center at CMS. So before our first presentation of the day, we are honored to have our open remarks from Dr. Liz Fowler, the Deputy Administrator of CMS and the Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to the President Obama on Healthcare and Economic Policy at the National Economics Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Liz, welcome.
Thank you, Dr. Sinopoli and Dr. Harden. It's great to be here today and nice to begin this year's series of theme-based discussions on performance measurement. Let me also say, we were just talking a little earlier, we're really glad that the House and Senate were able to pass legislation to keep the doors of the government open. It was a little touch and go whether CMMI would be able to join you this morning, so I'm glad it worked out for us to be here. I wanted to also thank, before I begin, the ASPE staff who coordinate this meeting for bringing together, again, yet another fantastic set of panelists and topics. We're excited to learn from all of you over the next 2 days. As we start the 2024 theme-based discussions, I wanted to just spend a moment talking about the importance of PTAC and the impact this committee has had on CMS innovation models. As many in ASPE know, and perhaps some of the PTAC members also know, prior PTAC submissions have influenced the design of several of our prior models. Primary Care First, which was influenced by AAFP and the University of Chicago submissions, the Oncology Care Model and its successor, the Enhancing Oncology Model, both influenced by submissions from Hackensack, Meridian Health, COA, and ASCO, and then our Kidney Care Choices Model, which was heavily influenced by the Renal Physician Associates. The last couple of years, PTAC has shifted to theme-based meetings, and I wanted to highlight that this shift has been particularly helpful for the Innovation Center. The healthcare landscape is very different from when CMMI and when PTAC were first established. The challenges we face in moving to value-based care are more complex. Our models and initiatives overlap in ways that they didn't when CMMI first started launching models, and our models take this into account and have tried to evolve as a result. And so has the work of PTAC. Maybe one example to note in particular, as the Innovation Center has tackled integration of specialty care and primary care, PTAC's theme-based discussions have been instrumental to our work. For example, in the development of the specialty integration strategy and the policies in making care primary. Over the next 2 days, the Innovation Center is really excited to hear from PTAC members and the expert panel discussions to learn more about performance measurement, where it is today, where PTAC thinks performance measurement can go by 2030, and particularly as it relates to population-based total cost of care models. I'm also excited for the panel discussion with CMS's quality leadership, which will happen tomorrow, so you can hear from other leaders at CMS, not just the Innovation Center, but other leaders in the agency about where performance or quality measurement is today and where CMS and the Innovation Center is hoping to go tomorrow. But I wanted to introduce, in the time I have here, transition to Dr. Susanna Bernheim, who is our acting chief medical officer and our chief quality officer at the Innovation Center. She's going to provide the rest of the opening remarks and then is our lead on the panel tomorrow. So, Susanna.
Thanks. I'm really happy to be here with all of you today. As you can imagine, I'm thrilled by the topic of the panel today and tomorrow, and you've assembled just an amazing group of folks to hear from. So thank you for this work. Performance management is a critical tool, provides insight and incentives, but it really needs to matter to patients and it needs to make sense to our clinicians for it to work. And we need to continue to evolve our system. We've been working a lot in the agency on alignment of measures, thinking about the burden and the task, but we also need to continue to look forward and think about how measurement can be used as a tool to make care better. So I wanted to say a couple of words now about the focus at the Innovation Center on quality, and then we'll talk more tomorrow in the panel. We're really trying to center our new strategy on the transformation of healthcare for person-centered outcomes and experience. And as you know, when the Innovation Center was started, the Affordable Care Act gave us two paths to expanding models if they were successful. One was if we reduced spending and maintained quality, but the other was that if we could show that we improved quality while maintaining spending, that also creates a path for expansion of models. And so we're really early on appropriately focused on spending reduction, but we're trying to rebalance the emphasis. Spending reduction will continue to be an importance, but really committed to broadening our definition of success and seeking a path to improving quality in all of our models. Again, I'll talk about this a little bit more, but a sneak preview, we're going to talk in more detail at the CMS Quality Conference, which is in Baltimore from April 8th to 10th, about the new quality pathway, and we have a publication coming out about that. And I'll just say two words about sort of what that focus is. It's really around aligning all of the pieces of our model around quality improvement efforts. It's around making sure that we're looking at outcomes and experience, including those measures that come from the voice of patients, doing that as our systems and clinicians are capable, aware of the burden that's associated with the evolution of measure and trying to do that in a strategic way, but knowing that this is a direction we need to go. And finally, thinking about how we evaluate our models to be able to show when we've made changes that are really important to patients and clinicians. So more on that tomorrow, but this is an incredibly timely discussion for us, and I'm grateful to be here and for your work.
Good. So thank you for sharing those remarks, and we appreciate your continued. Got something else to say? No. Okay. Continued your support. We really enjoyed it, and we felt as PTAC the increased engagement from CMMI with your leadership, and just really enjoy the constant conversations that we've had and the input that you've given us. So appreciate that. Thank you. Thank you. All right. So for today's agenda, we'll continue to explore a range of topics, including defining performance measurement objectives for total cost of care, selecting and balancing between the number and types of performance measures of total cost of care models, best practices for linking performance measures with payment and financial incentives in total cost of care, addressing challenges related to implementing performance measures, and incorporating health equity and the patient experience into performance measures. The background materials for this meeting, including an environmental scan, are online. Over the next 2 days, you'll hear from many esteemed experts. I think we have great panels put together. We have worked diligently to include a variety of perspectives throughout the 2-day meeting, including the viewpoint of previous PTAC proposal submitters who addressed relevant issues in their proposed models. I want to mention that tomorrow afternoon we'll include a public comment session. Public comments will be limited to 3 minutes each. If you'd like to give an oral public comment tomorrow but have not yet registered to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. The discussion materials and public comments from the March PTAC public meetings will be incorporated into a report to the Secretary of Health and Human Services on how to develop and implement performance measures for total cost of care models. The agenda for today and tomorrow include time for the committee to discuss and shape our comments for the upcoming report. Before we adjourn tomorrow, we'll announce a request for input, which is an opportunity for stakeholders to provide written comments to the committee on developing and implementing performance measures for total cost of care models. Lastly, I'll note that, as always, the committee is ready to receive proposals on possible innovation approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about how to submit a proposal on the PTAC website. At this time, I'll invite my fellow PTAC members to introduce themselves. Please share your name and your organization. If you would like, feel free to describe any experience you have with our topic. First, I'll go around the table, and then I'll ask our members that are joining remotely to introduce themselves. I'll start with myself. I'm Angelo Sinopoli. I'm a pulmonary critical care doc by training. I have spent most of my career as a chief clinical officer in large health systems and building and driving large clinically integrated networks. Built a enablement company where the focus was care management, but also defining and building quality metrics and performance metrics, implementing those across the networks. And so I had some direct exposure with this, as many of us have. I am presently the Executive Vice President for Value-Based Care at Cone Health System in North Carolina. Next, I'll turn it to you, Lauren.
Thank you, Angelo. Good morning. I'm Lauren Hardin. I'm a nurse and Chief Integration Officer for HC2 Strategies. I've spent the better part of the last 20 years working on models, innovation, and design for complex and underserved populations, and have been part of starting the National Center for Complex Health and Social Needs. Currently work across the country with different communities, building connected community of care approaches to underserved and complex populations.
I think next we'll go to Josh, who I think is on Zoom. Josh, are you there?
Yes. Can you hear me?
Yes.
Great. Good morning, everyone. Joshua Liao, internal medicine physician and professor at the University of Texas at Southwestern Medical Center, where I also lead the Division of General Internal Medicine. Over time, I've had the opportunity to work on leading, implementing population health and care transformation programs for a large integrated regional health system. In that setting, I've also had a portfolio of work studying and evaluating payment models relevant to and consistent with many that PTAC talks about in my research, and working with a number of different decision makers on how do we design these programs. It's great to join.
Next, I'll start with Jennifer on my left, and we'll just work around the table.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality and Patient Safety Officer at UC Health for Metro, and we are the largest integrated healthcare delivery network in Colorado, serving patients throughout the Rocky Mountain region. I'm also co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions to help improve patient care and outcomes. And I'm a tenured professor at the University of Colorado, an emergency physician by training. I also co-authored an alternative payment model that was considered by this committee.
Good morning. I'm Walter Lin, the founder of Generation Clinical Partners. We are a group of providers based in St. Louis, caring for the frail, elderly, and senior living organizations. The founding mission of Generation Clinical Partners was to help senior living organizations transition into the world of value-based care. And I have a special interest in finding payment models that support clinical models to deliver higher quality care to this population.
Good morning. My name is Jim Walton. I'm a general internist by training. Started my career in Waxahachie, Texas as a rural health physician, and transitioned to caring for the poor and underserved in Dallas with Baylor Healthcare System, and migrated my career into as a chief health equity officer for Baylor, and then eventually became a CEO of a large physician organization that moved into value-based care. called Genesis Physicians Group. Just recently retired from there and now running my own healthcare consulting business focused on Medicaid value-based payment models for rural Texans and folks in Louisiana. I'm doing some consulting work.
Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas. I am also a medical director with One Medical, a national primary care group. And I think my experience with quality, I've served for years previously on the NQS Primary Care and Chronic Illness Standing Committee. Also have my certification in medical quality. Good to be here.
I'm Dr. Larry Kaczynski. I am a gastroenterologist by training and spent 35 years in the private practice of gastroenterology, built the largest gastroenterology practice in Illinois at the time. I have spent the last 12 years of my life in value-based care. I'm the founder of Sonar MD, a value-based care company for deployed into patients with inflammatory bowel disease. I am its founder and currently a board member. I'm also on the governing board of the American Gastroenterological Association. My focus is on developing solutions to bring specialists into value-based care, both independently as well as part of population-based total cost of care models.
Good morning. My name is Terry Lee Mills. I'm a family physician by training with additional focus in clinical informatics and hospice and palliative care. I started in rural private practice in central Kansas, then moved into medical group leadership across several states, and then most recently as CMO of a regional provider-owned health plan focusing on MA, commercial, and individual exchange lives. I've been throughout that path focusing on quality improvement, clinical transformation and efficiency, and value-based care, including metrics from several different perspectives. So excited to hear the conversation coming up.
Thank you, PTAC members. We have two PTAC members who are unable to join us this morning, Dr. Jay Feldstein and Dr. Chinny Palura. We do want to thank them for all the contributions they made prepping for this meeting today, though. So now we'll go straight into our first presentation. 4 PTAC members served on the Preliminary Comments Development Team, or PCDT, which has worked closely with staff to prepare for this meeting. Jen Weiler was the PCD lead, with participation from Larry Kaczynski, Chinny Palura, and Jim Walton. I'm thankful for the time and effort they put into organizing today's agenda. I know how much work they put into it. We'll begin with the PCDT presenting some findings from their analysis to set the stage and goals for the rest of the meeting for the next 2 days. Additional background materials are available on the ASPE PTAC website. PTAC members, you will have an opportunity to ask the PCD any of the follow-up questions after the presentation. And now I'm going to turn it over to Jen.
Great, thank you, Dr. Sinopoli. And as you said, I cannot thank enough my colleagues, Dr. Kaczynski, Dr. Palura, and Dr. Walton, in addition to NORC and ASPE staff who were instrumental in helping us put together our presentation today. So what we'd like to do is summarize do a landscape assessment of this very broad space around quality measurement, not only development, but also implementation, challenges, and how they affect population-based total cost of care models, and importantly, care delivery. So our objectives for this theme-based meeting are to first discuss performance measurement objectives, then to determine how best to measure what the desired outcomes are, because we know that's easy to say and really hard to do. To discuss the issues related to developing performance measures for these types of population-based total cost of care models, including identifying the appropriate number of measurements, the types of measurements, and then how to incorporate important components like equity and patient experience, as we've talked about already this morning. We'd also like to hear from our experts over the next 2 days about discussing approaches for linking performance measurements to payment and financial incentives, and what are challenges and best practices. So what we have done is summarize our previous experience and evaluated that PTAC has received 35 proposals for physician-focused payment models, and we deliberated on the extent to which 28 of those models in the past have met the Secretary's 10 regulatory criteria. I think it's no surprise to anyone that of the models that we evaluated, nearly all of them that had been submitted to PTAC included some component of performance measurement. And we found that 60% of them, through our deliberations, met criterion 2 and 4, which are quality and cost and value over volume, respectively. So what we'd like to do today is start with framing an approach to performance measurement understanding, and again, an approach to how these measures can and should be used in population-based total cost of care models. So our working definition that we would like to propose for performance measurement and used for this analysis is that performance measures assess and monitor all aspects of participants' performance within the models, which include quality, both process and structure, outcomes, cost, and utilization. We spent a lot of time thinking about how do we describe this very dense area around performance measurement, and would like to propose this rubric. And really, these are the guiding principles and types of performance measurements that we think can and should be within population-based total cost of care models. So on the outside of the wheel are the guiding principles that we believe should and are the driving forces of moving the gears inside. The gears are the measures to evaluate those principles, and at the core is the patient experience and care delivery team effectiveness. So again, on the outside of the wheel, patient engagement, care coordination transitions, equity, efficiency, and proactive patient-centered high-touch care. We think those should be the guiding principles to the measures, which are outcomes, utilization, cost, and quality, of which there are many that further delineate each of those subcategories. But what we thought would be helpful is giving a clinical example to specifically describe what we just showed. And as we know, patients go through stages in their health journey, from health maintenance all the way through disease management and ultimately to palliative care. And each of these stages conforms to occurrences or conditions that providers appreciate, like in this example here for liver disease. If we overlay the wheel of guiding principles and metrics to evaluate this rubric that we just showed you, that could be one way that ultimately we develop clinical measures that are meaningful, both process and outcomes, cost and utilization. Again, in this example, we show a patient with elevated liver enzymes who then progresses through end-stage liver disease, and how those guiding principles of proactive, patient-centered high touch, patient engagement, care coordination transitions, equity, and efficiency may be applied. So what we did next was do a landscape assessment of our current performance measures. And to start this landscape assessment, we used this approach. First, we asked what care outcomes should be a focus in population-based total cost of care models. Then, what process measures drive to that outcome? Next, what current measures exist for evaluating this care? Next, what are the performance gaps in these current measures? And finally, how to link performance measures with financial goals. So what we found in our landscape assessment by doing an analysis of information in the CMS Measures Inventory Tool, CMIT, we found that there were 24 Medicare pay-for-performance or pay-for-reporting programs. Currently, there are 618 performance measures that are used within these 24 model programs. And interestingly, what we found is that of these measures, 61% were unique, meaning used by only one program or model. And we believe that what this acknowledges is that there may be unique care delivery locations, conditions, or processes. However, what we found was interesting is that it may be challenging to scale these measures to different groups that participate in multiple Medicare programs. And additionally, when we did this assessment, we also found it interesting that 59% of the measures that are currently used were not endorsed by a CMS consensus-based entity. When we did this evaluation of these 24 programs, we also found, maybe to no surprise, that a majority of the measures, half in fact, were related to the MIPS program. Now, we recognize that participants get to choose at least 6 quality measurements, one of which must be an outcome measure from the full set, and that CMS ultimately performs a calculation of performance, and that participants are not scored on all of these measures. However, a majority of the current measures are located within or contained within this MIPS program. When you look at these measures, we also found that the distribution of the current measures is primarily focused on process measures, 52% in fact, and an additional 39% were related to outcome measures. Further, when we evaluated these 24 programs and models, we found no surprise that almost all of them had some link to payment. That said, the types of linkage varied from pay for reporting to pay for performance. Here's just a couple of examples of those programs. However, what we did find interesting in doing this assessment is that there was no clear association between the number of performance measures and the percentage of financial risk across the 24 program models that were analyzed. Which I think it's important to say, this leads to a number of questions, and it may actually impact physician and clinician participation in programs, which I'm sure we'll hear about when we speak to our experts. Now, there's a couple of different types of programs that exist, those related to quality and outcomes, and those programs that are related to utilization and cost, which we included here as part of our assessment. But really what we thought we would do is spend the majority of our time diving into what we believe are some of the challenges to developing and implementing these performance measures and the programs. This is a summary of what we found. Again, this is not meant to be exhaustive, and what we expect over the next 2 days is we will hear more and want to hear from our experts around surfacing these challenges, really diving into where those opportunities are, with the hope that then we can identify best practices and figure out solutions. But in our landscape assessment, we found these broad buckets of challenges that included identifying first, meaningful measures, ensuring that we have measures that are clinically meaningful to patients and clinically relevant to providers, where one might think that those things are correlative, but interestingly, they are not always. In addition, I think we all understand that these meaningful measures need to enhance value-based care. We also found challenges related to the measure development process, the administrative feasibility of not only developing measures, but reporting on measures, the data collection infrastructure needed to do that, and the availability and timeliness of performance data, which is ultimately needed to inform changes of behavior, care delivery systems, and outcomes. So let's dive into this a little bit more, each of those buckets I just described. First, under meaningful measures and the challenges. Currently, there's little evidence that public reporting of measures is linked to improved overall quality of care in the United States. Just one example of an assessment that was done of the CMS Hospital Compare program when looking at risk-adjusted mortality for heart attack, heart failure, and pneumonia. There was no improvement in risk-adjusted mortality outcomes. Second, what provider scores on performance measures may not necessarily be associated with patient outcomes. We were interested to find in one study of the MIPS program that nearly 1 in 5 primary care physicians in 2019 received a low performance measure score. However, their health-related outcome score was high, which is not intuitive, and interestingly, that it's not only not correlative, but it's the exact opposite of what one would expect. And then third, when we think about the patient-reported outcome measures or PROMs, we acknowledge that this is a promising approach to measure not only patient symptomatology and their self-assessment of care, but also health status. But currently, there's limited peer review literature on what are the ideal PROMs across all different types of patient care conditions and clinical specialty areas. The next challenge is around the length and resource intensity of measure development process, which is not insignificant. The development of new measures involves multiple steps that can take on average 5 to 6 years to complete. Indeed, completing just the endorsement process may take up to 6 months between the time a measure is submitted for endorsement to the time when an endorsement decision is made. In addition, there's time and resources that are required to adapt these measures for use in value-based care programs. For instance, a 2021 GAO report showed that a stakeholder group that was working with CMS for 3 years worked with CMS for 3 years to convert 7 pathology-specific registry measures into the MIPS program. Although one might think that that's unique to this specialty, there are examples across many other specialties where there is an aligned incentive to identify outcomes and process measures that are important to care outcomes, but that the process just takes a very long time. The other challenge is around administrative feasibility. We found that quality reporting places substantial administrative burden on physicians and staff. Indeed, just one study of physicians and staff, they estimated that 785 hours were given per physician annually to manage quality measurement, not just care delivery, but ultimately reporting. And that the greatest amount of time was spent on entering information into the medical record with the only purpose for reporting quality measures to external bodies, not necessarily actually for care delivery. And it's estimated that the time coordinating and managing quality measures on average translates to $40,000 per physician, which is considered, as we all know, administrative overhead, and really an opportunity for us when we think about cost savings, where we'd rather be focusing those dollars on delivering care to patients. Next, under administrative feasibility, one additional challenge is measure consistency. And our group thought it was really important to surface this because those of us who are in the field doing this work every day, this is actually a big pain point for us. In a national survey of physician practices, 46% of physician leaders reported that they were working with measures that are similar but not identical, and this was a significant burden. And I'll give you just an example in my current day job. The risk adjustment methodology for the mortality metric of observed to expected is different across 3 different types of programs, both within the Medicare space and outside of the Medicare space. Yet, as my healthcare delivery organization is required to report on all of them, and then I have to explain to our board of directors why I have 3 different numbers for 3 different groups of patients that actually don't look any different from a demographic perspective. Next, the analysis of this data of the 24 program models found that 26% of the current performance measures within the CMS measure inventory toolkit or tools were used by more than one program or model, and many of them had different numerators and denominators. I will note that in our presentation today, we have a very dense appendices that has lots of details of some of these things that I'm describing, and the reference list for all of the data that we're providing is in that and available. Next, the data collection infrastructure is challenging. Currently, we found in this assessment that 54% of current performance measures are from electronic sources, and I think that that part is not surprising. But what I do think we found interesting is that although some of these are through claims data, the EHR vendors, and the non-electronic clinical data space, it's worth saying that for instance, in this registry space, there may be some additional direct and indirect costs. So the cost for participating in the registry, and then the cost for the administrative oversight of collecting the data, sometimes within organizations manually, and then also submitting it. We also found that 40% of current performance measures then are using multiple data sources. So again, administrative burden related to trying to not only collate the raw data, but to send it, and then ultimately the cost to bring that data back, aggregate, and analyze. Next, the availability and timeliness of performance data was an area that we identified as a challenge. And of course, this is going to be impacted by the variability of the databases that I just described. But for instance, we found that it typically takes 5 to 6 months after a healthcare event to finalize Medicare specific administrative claims data, with updates that may continue well beyond 12 months. In addition, the cost and utilization data that goes into the HCUP program or the Healthcare Cost and Utilization Project is available 18 months at the end of the year. So that timely, actionable component is really challenging, ultimately when we need to make decisions around how to do improvement work. And when there's over a year of delay, that can be very challenging. So those were the challenges related to developing and implementing measures, but we also thought as part of our landscape assessment, it was worth elevating the challenges related to linking these measures to payment. Again, we use the same approach to summarize the different categories of work that we think needs to be done. And just to say it, each of these areas could be an entire presentation in and of itself. But just to go through it briefly, creating meaningful financial incentives for improvement that incentivize care that is high value and evidence-based is the goal. There are different types of financial incentives that do work. There's data that shows in the pay-for-performance space, for instance, in one study, clinics that had a pay-for-performance incentive increased the rate of a recommended medication to prevent thrombosis from going from 12% to 6%. Sorry, it's going from 6% to 12%. And that actually large incentives may have a greater impact. We found additional data in one study that showed that when there was an over 5% of salary or usual budget tied to performance measures, there was 3 times the effect of the program than on smaller incentives. But what was interesting is that this correlation of amount of incentive was not consistent across the peer-reviewed literature. We found another study by Rodriguez et al. That found that actually smaller incentives were linked to greater improvement when related to a provider communication program as opposed to larger incentives. So again, there's variability on does money make a difference? Yes. How much money? Actually, it looks like it may be variable. So we're going to be really interested to hear from our experts to hear if they have any opinion, about an experience in that space and give us some recommendations. In addition, there was a challenge around timeliness of payment. In one study, we found that physicians significantly preferred, no surprise, to have their bonus payments made in a more timely way, 6 months instead of 12 months. And not only did we evaluate what was the impact around financial incentives, but there was also a body of literature looking at financial penalties. And one program that was in the surgical care space found specifically that there was a positive impact on patient care when penalties were used, but interestingly, there was no impact on patient care when incentives or rewards were used. So again, I think that's an interesting space for us to dive into with our experts. So we understand that ensuring equitable outcomes is a desired outcome of population-based total cost of care programs. And linking payment to performance is one component, but what we noted is that these pay-for-performance programs may disproportionately penalize providers that serve lower socioeconomic classes or vulnerable communities. For instance, safety net hospitals, when there's been previous assessments that have shown that when safety net hospitals were disproportionately penalized in the CMS value-based purchasing program and the hospital readmissions reduction program, there was then in 2019 an HRIP update to stratify these benchmarks to try to acknowledge those challenges. There are a number of different methodologies that are currently being used to not inappropriately penalize groups who are providing care to these vulnerable communities, but there's still not great literature around how to do that in a cost-effective and high-quality way. Finally, preventing unintended consequences we thought was important to mention. Pay-for-performance programs may unintentionally create perverse incentives. And these were just three that we wanted to call out. The first was that by creating focus on certain measures, there may be a hyperfixation on care delivery for those measures where there is lack of focus on other care that is important. So an inappropriate measure fixation, for instance. There's also an acknowledgement that measures may create a perverse incentive to divert care or focus away from important clinical areas or to just focus on healthier patients to prevent penalties for caring for instance, more vulnerable patients, as we just discussed. So gaming the system or create shifting of care patterns and avoidance in treating disadvantaged, underserved, or high-cost patients, which may result in colloquially patient dumping. We acknowledge that there's a challenge around how to create a risk adjustment methodology to acknowledge the last two challenges that I just spoke about with regard to equity and preventing unintended outcomes. Risk adjustment we have talked about a lot in previous meetings, and actually think there's even more to dive into that we hope we can over the next 2 days. That said, we know an entire meeting could just be dedicated to this. However, briefly, we thought we would, in our assessment, landscape assessment, we identified that 12 out of the 14 CMMI models, so 86%, use a risk-adjusted methodology, of which 30% apply the CMS hierarchical condition categories risk scores, and the other 8 or 71% use different risk stratification and risk adjustment methodologies. Again, that creates a challenge when doing data and analytics, creating appropriate comparator groups, and makes one wonder, is there an ideal methodology that exists if there are so many that are currently being used, and where is that opportunity? Benchmarking is also challenging then, because risk adjustment leads directly into then comparisons, both internal and external. We note that national benchmarks do not account for geographic differences in patient populations and may unfairly penalize certain types of providers. At our last meeting, we actually had a robust discussion about this with regards to rural care delivery systems and providers. And based on our analysis of 14 selected CMMI models, 43% of those programs use benchmarks that are related to national data rather than regional, local, or provider historical payment. With regards to benchmarks, there's also a known challenge that we wanted to make sure that we acknowledged, and that's around the use of performance thresholds. There's this idea of an absolute threshold, which is consistent and transparent for all providers, but it might not promote improvement for providers that already meet these thresholds. So high-performing organizations typically will continue to be high-performing when these benchmarks are used. There are different types of thresholds, which are relative thresholds that do promote continuous improvement of organizations, but it may reduce collaboration between high-performing and low-performing groups and actually create persistent gaps and encourage, let me say it a different way, it would not encourage collaboration, which is ultimately what is needed in population-based total cost of care models. And this is actually the predominant model in the CMMI models, of which we noted 86% had the relative threshold benchmarking approach. So again, I want to thank my colleagues on the PCDT team, and NORC and ASPE staff for helping us to do this landscape assessment. Again, there is lots and lots of detail behind what I both presented and did not present today in our appendices. But we really wanted to conclude by focusing on where we started. And this is what we think the relationship should be between the guiding principles and the types of performance measures within total cost of care population-based models. And again, focusing on the core, the patient experience and care delivery team effectiveness. We think if we use this rubric in thinking about how to not only do model development, but implementation and assessment, that this is a way for us to help our collective goals. So in the next 2 days, we hope that we will have the opportunity to focus on the things that I've just discussed, developing objectives for the performance measures for population-based total cost of care models. What do we want to measure in these models and how? We hope to hear about that from our experts. We want to hear more about the issues related to selecting and designing measures from folks who actually have that experience. We really want to hear about best practices to measure development, utilization, and financial and quality outcomes, and then ultimately hear about this unique component around linking performance measurement to financial outcomes and what has been successful and not successful in the past, and how that can inform moving forward. And with that, I'll turn it over to my PCDT colleagues for any additional comments.
Jen, you did a fantastic job. I don't know how much more I have to add to it, but a couple of points just to emphasize. First one is time, the time to develop these measures and implement them, whether we did it in a fee-for-service world or in a population-based total cost of care environment. We've got to figure out a way to shorten the time period it takes to actually implement them, and implementing them meaning they are actually in the workflow of care without a physician having to do something outside of that care in order to document it. We also have to make sure that process does lead to outcomes. This is very, very important. We spend way too much time on process measures that have never been demonstrated to result in an outcome. My third point would be We not only have to have these applied to primary care physicians, they certainly have to be applied across the specialty space, and we can't forget the patient. Those patient-reported outcomes measures are critical. And then finally, to close it, we can't just deploy these and throw them out into space. We have to reevaluate them. We have to make sure that what we developed is actually producing the outcome that we intended it to produce. And if it isn't, we need to be changing them.
Thank
Yeah, my only emphasis would be, by the way, great job, was that physicians are increasingly, ever since these measures connected to value-based work had gotten launched, physicians kind of communicate that this is oftentimes an administrative paper chase through the computer and that they're not necessarily relevant. So I think the data supports what we're hearing from the field from our colleagues. But the thing that I really want to elevate was that doctors, just like patients, are practicing in milieus that are high risk, and that's captured oftentimes now in the area deprivation index. And I think it's really would be helpful, and I'm glad to see that we were able to elevate that here, that digging deeper into the impact of ADI or other measures that can kind of help us index for our colleagues, our physician colleagues, the environment with which they're trying to make progress on patient reported outcomes. And so I thought it would just elevate that.
Thank you all. I think, unfortunately, we're running out of time here. And that's going to generate a lot of great questions for the next 2 days. It was a fascinating report. And just as you were going through it, just lots of questions going through my mind and things I wanted to ask, but we'll make sure they get asked over the next couple of days. So Jen and PCD team, I want to thank you for all that hard work I know you put into that. It was pretty detailed work. So at this time, we're going to take a break until 10:30. Please join us to hear from our great lineup of speakers starting then. And the next one will be on developing objectives for performance measurement for total cost of care. So we'll see you back at 10:30. Thank you.
Produced by the U.S. Department of Health and Human Services.